Good afternoon and welcome to today's program titled Financial Best Practice for Emergency Services Revenue Cycle. My name is Jacqueline Fitzgerald and I am the Director for NARI. I will be your moderator for today's event. Our program will be 60 minutes in length. Note that an on-demand version of this program will be available approximately one day after the completion of the event and can be accessed using the same login link that you used for the live program. Today's program is sponsored by Vitalware. Thank you to our sponsor and to you and our audience for giving us your time and attention. Before we get started, we have a few housekeeping details. First, to ensure that you can see all the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Second, you will find a resource list for today's webinar in the lower left of your screen. Here we have listed the webinar slide deck for you to interact with. Third, at the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. At this time, it is my pleasure to introduce you to our speaker for today's webinar, William L. Maum, ND, CHIAP, CRCR, CMAS, RN, is the Vice President of Client Strategies for Vitalware. Thank you, William, for taking the time to speak with us today, and with that, the audience is now yours.
Thank you, Jacqueline. It's a pleasure to be here this afternoon. As always, we have to start off with a little disclaimer, and I also want to note that we're having a bit of rough weather where I'm podcasting from. So if you should lose me, stand by. They'll give directions as to what the next step would be. Quick disclaimer, this webinar was made in its current as of today, so it could change tomorrow, whatever. Any reference to revenue codes is solely the American Hospital Association NUBIC copyright, and any reference to CPT is that of the AMA and may not be duplicated without permission. As we go through today's agenda, we're going to review the revenue cycle. And the reason ED is important is as we come off COVID and all sorts of things that have happened in this calendar year, we have to understand that hospitals are basically reopening again. And that means that the changes that occurred with COVID to the ED are they're going to start increasing again. While volumes may be up or down in your area, they will change again. And this is bringing the reason for this presentation today, being that we need to get back to basics again. So we're going to talk about the key elements of the revenue cycle, the importance of charge capture, and how it may be maintained and efficiency improved through documentation methods. Use of automated charge capture scrubbing will be definitely a discussion. And then facility to provider comparison for charge leakage. I mean, that will be more of a discussion near the end. Objectives is just failure successes begin with your first patient presentation. So when they walk in the door, the revenue cycle is starting. It's not starting when the nurse sees them. It's not starting when billing starts. It starts at first presentation. And from that point on, documentation can make or break your capture. So we'll go through that. And then the differences between physician and facility charging requirements and how to create an internal product for root cause. When we look at the importance of revenue integrity, there are two sources of true income for an institution. Those that plan, such as your elective procedure, diagnostic therapeutics, that have been hit pretty hard by the COVID with the decreased elective procedures, and then those unplanned and episodic. They have slightly different revenue cycles, and when you're looking at the mainstream for unplanned and episodic, it's going to be your emergency services area. These are non-electives. People walk in and you have to stabilize, treat, and make those next decisions. So it does constitute the singular gateway to unplanned services for the facility, and leakage at that point represents a huge revenue risk. So we're going to go and we're going to do a polling question now. And at this point, we're going to read the question. In your facility, which entity is responsible for training the compliance team with training and compliance with EMTALA? So in your facility, which entity is responsible for training and compliance with EMTALA? You should have some polling areas to cast your vote. We'll keep it open for about 30 seconds. Number one choice would be your compliance officer or committee, a privacy officer, a medical staff member, nursing staff, or other. Again, we'll keep this open for about 30 seconds so that you can vote. In your facility, which entity is responsible for training and compliance with EMTALA? Either your compliance officer or committee, your privacy officer, a medical staff member, a nursing staff member, or other. We'll give you a few seconds longer to go ahead and cast your vote. About 5 more seconds, and then I'll close the poll. Okay, let's see where we are. 68% of you said the compliance officer, and that's not surprising. But when you see the compliance officer in all this, you tend to see them in medical necessity, and you see them in other areas other than the ED. So this EMTALA, when we get right down to it, we don't hear a lot about that, and it's somewhat of a word of mouth. It's not in your yearly annual competencies as a general rule. We also see other, 18.8%. That kind of surprises me. I don't know who the other is. So if you want to write in your chat box, we can come back to that. And then medical and nursing staff constitute about just a little over 10%. So this makes sense. About 68% is with your compliance officer. So we're going to start with EMTALA. And this is a huge difference between planned and unplanned services. So EMTALA is an overarching requirement for emergency services that requires that the patient has to be stabilized, a medical screening exam be done when it is requested. You cannot delay care for the purposes of finding financial information. And the patient may not be dumped on another facility until they're stabilized or what have you, and they can't be discharged till they're stabilized. So this EMTALA has a lot of tentacles, more than we can cover today. There are whole websites designed for this. EMTALA FAQs is a good website if you have further questions. And then here from the American College of Emergency Physicians tells you some legal things. The medical screening, this is the key. The medical screening may not be delayed to inquire as to the patient financial services. So sometimes when I'm doing consulting work, I will sit in registration and see what they do. And unfortunately, many of the times the registrar is left into a position of determining, where they're at. And so they'll be asking for full financial information. The patient's clearly not stabilized. Just because they're not in the back and they're still in the waiting room doesn't mean that they're stable. So we should make a process of only doing the short reg, no matter what. Just enough information to ensure a medical record can be created, ordered, performed, medical record number isn't duplicated. So basically your name, your age, your date of birth, and maybe the last 4 digits of a social or something that is, you can identify it to make sure you're not creating another record. But if you're unsure, it's okay, create the record, and then there are teams within HIM that can combine these. The second phase is a full registration that includes insurance coverage, eligibility, guarantor, subscriber information, and that's usually the benchmark is to perform that at the last part of the encounter. As the patient's about ready to be discharged, and do it at the bedside. Don't bring them up to another area, because patients will get out the door faster than you've ever seen in your life, and you miss the opportunity to be able to get all the correct information. Also, when you're doing the full reg, you need to be able to ask probing questions and not just say, hi, I see you live at 815 Smith Street. Is that your address? Or, let them tell you. Or is your phone number changed? That's what I hear a lot. Has your phone number changed? Do you still have the same insurance? You need probing questions. They need to do it every time. So we're going to go on to a quick overview, and this is a Visio of how an ED revenue cycle looks. And you can see that there's a green box that EMTALA is satisfied. And that kind of is, there's 2 steps to the charge capture. One, you have to satisfy EMTALA, and 2, you have to charge and document. So that you'll see them taking 2 paths, but they all end up at the pre-bill edit. Once the itemized bill is created down on the lower right, then it goes through phase 2, which is the billing cycle. So we're going to split them up today. So the first phase is data acquisition and EMTALA requirements, registration, short reg, clinical provision of care, post-EMTALA, acquisition of demographics. Then the charge capture begins. Now, charge entry, that's key. How is it being done? Is it manual? Is it up to nursing? Is it up to an ancillary staff member? Or is it being done automated through documentation? Charge reconciliation. This is a huge loss leader in the ED because very seldom does ED do charge reconciliation. So, you know, if you had 300 visits that day with 6 left without treatments, you better have 294 evaluation and management codes. And seldom do we reconcile. Some of the systems are now being able to do those reconciliation processes for you. I believe in Epic ASAP, there was some thought that they could do that. I haven't seen it personally, but I did hear that it was possible. Then there's CDM soft coding and HIM hard coding. And this is another area where the charging mechanism is both soft coding and hard coding in the ED, and you have to make sure that they both work in tandem. Then you get into billing, which is your pre-bill edits, your itemized claim, the bill scrubber, and the creation of the 837. So what I hear a lot of times from ED staff when I work in the ED too, they say, oh, don't worry, billing office will take care of it. They can't take care of something you never charge because they're never going to see it. So that's a misnomer. And then reimbursement. Your key processes that make this successful are and will continue to be complete and accurate documentation. And I find that documentation's been made more complex with the electronic medical records and templates that were designed by somebody that doesn't work in the ED, therefore they're not optimized for ED personnel. So the key here is to get a nursing informatics person to work with the ED staff to make sure that your templates are in fact organized. Complete and accurate charge capture, and that means you have to know what's going on with the patient in order to reconcile that before you discharge them. Comprehensive pre-bill review. That means not checking 5 claims from the day before or 5 visits from the day before. That means 100%. That you need to know the entire universe to be able to say, I didn't lose charges or I didn't duplicate charges or they're on the wrong account. So a high clean claim rate, which is when you create an 837 and it goes to the bill scrubber, you need it to be very high. Timely claim submissions. So not waiting on late charges. If you have a late charge problem, which happens quite frequently in the ED, that needs to have like a 6 Sigma review and a root cause that can be remediated. And then timely reimbursement, no overpayments or underpayments. When we look at this phase, we see that, you know, this is the charge capture phase. And you see MD orders and services rendered. But unless this EMTALA is satisfied, it's not going to go to the pre-bill edits. It's not going to release them. And then charges entered into the clinical system. Now, over on the far right, you see charge reconciliation. And this is absolutely the building block of charge capture. You have to have the right patient with the right charge on the right data service. So I do an enormous amount of charge capture reviews. And I will tell you that most of them fail because the ED visit was on one day and the surgery is listed on one day, but the supplies are another day, or the radiology is the following day. So the from and through date on the bill say it was June the 4th, but I have radiology charges that are posted and say on the 5th. So they're gonna error out. So that's a big problem is data service. Also CDM. Is the CDM mapped correctly? So you have the correct elements in the CDM, but if the mapping from the ER module or radiology module or lab module or pharmacy module is not accurate, then there's no conceivable way you're going to get the charge on the bill correctly. And one example I have that makes brings a point. There was a very small hospital in Texas I worked with at the beginning of my career, and they were being looked at for an abundance of charges for angiograms. The problem was they didn't do angiograms. And what had happened is the CPT code in the CDM was mapped to the wrong procedure in the radiology information. So every time they did a 2-view chest, they charged out an angiogram. So it looks right in RIS, and it looked right in CDM, but when you looked at how they were connected wrong. So a lot of times with CDM, you just say, oh, well, it's fine, it looks good, it's been scrubbed. No, that's not the end of the story. And then HIM coding. Who's going to do those procedures? Is that HIM? Is that going to be hard-coded? And if it is a surgical procedure, what's the trigger for HIM to be able to get it? Because this is not a 360 revenue code, and a lot of times their encoders look for 360. So how are you ensuring that any procedure like a LAC repair or an IND that requires documentation is in fact linking up so that you get your surgical procedures? And then most importantly, there has to be edits on 100% of the services rendered, not on the claim, 100% of the services rendered. So we're going to move into polling question number 2. In this polling question, in the facility evaluation and management or visit is, and I'm speaking specifically of the facility E&M, not the physician. Is it derived through automatic point calculator in the system based on documentation? Is it derived through a chart review by coding or charge entry personnel based on policies and procedures? Is it entered, is nursing entering the E&M levels or other? So when a facility visit level is entered and determined, how is it being determined? Is it derived through an automatic points calculator in the system based on documentation provided? Is it derived through chart review by coders or charge entry personnel who are trained to come up with a level? Is it done by nursing, just nursing doing it all, or some other group? We're going to wait about another 10 seconds and we will close the poll. Again, make your choice in one of the boxes and we'll close the poll in about 3 seconds. Okay, so 44% of you said that it's done through an automated mechanism and a points calculator. 46% said it's by coding or charge entry personnel, and 8% says nursing, and then 0.8% saying other. This is not surprising. Most systems, Cerner, Meditech, Epic, they have a points calculator in there that was provided at the time you purchased the software. The issue with those is in some cases you don't have control over them, and you have to modify them for your specific facility. I still see a lot of people doing chart reviews and a point system, but when I go in and I look at the point system, I ask them to show it to me, their policies, procedures. They aren't really current, maybe not this year's or last year's. And then nursing is great, but the problem with nursing is some aren't full-time. Some are PRN, some are locums. So when you're dealing with nursing, the changeover, the shift change, the acuity level of the department can really impair the way that they select things. So what we find with that is we have a really sweet older couple that's super nice and wants to bring you cookies to the ER. The nurse says, oh, you know what? They're so nice, a level 1, they can't afford to do this. And then you have a patient who bites you and you say, you know what, they're a 5. So we have to take the human factor out of this and depend entirely on documentation. Clinical care and documentation is about 4 items. 4 specific things that you can bill for in the ED. Evaluation and management, which is a visit, and the physicians bill their side and the hospital bills theirs. surgical and medical procedures, the physician bills their side and the hospital bills there. And this is one area where, for the most part, at least in the surgical procedures, if you have physician coders and hospital coders, and that surgical procedure is not coded the same, it's likely to start to be looked at from an outside audit. So you really need to start doing comparison between your physician surgical and your hospital. You know, so I did a laceration repair and it's less than 5 centimeters, and then the physician code says 12.5. You know, they don't match. So the surgical code should match. The E&M will seldom, if ever, match, and it's not expected to match. The supplies won't be represented by the physician, and neither will the medications on their bill. So when you're looking at this, a large loss leader for charges is a good comparison between surgical and medical procedures. Clinical care must show that the MSC or screening exam was completed and documented in the record. We have automated stop points where the physician can order MSC completed, and so that it does appear in the record. It's becoming a litigious standpoint where people don't feel that they were evaluated, even though there's a full medical record. It's better to just get an order set that says it's done. Experiencing more documentation driven. So in the nursing, if we talk about providing a 12-lead EKG tracing, the documentation drives that CPT code onto the bill and charges for it at the time that it's completed. We talk about incisions and drainage. That drives the code if it's a straightforward. So we start to see more and more nursing documentation driving charges. Respiratory has done this for a long time with their aerosol. Once they document their aerosol, so there's an MD order, they document that they did it, how long, patient's response to the aerosol. Once that's done, it charges an aerosol. So we're seeing more and more of this. The issue with this is that when you set the template up, it had a certain set of documentation, but most systems don't go back and look at their documentation and say, is that still representative of the CPT code? Because CPT codes change yearly. The other one is pharmacy, and you will use the medication administration can drive charges for medication. And it also can help you figure out if you're missing the administration, the injection or infusion. The E&M, you're going to use for physicians the CPT book guidance, 95 or 97 for Medicare, and then there are new E&M codes coming out for 2021. But facilities, you're not going to do that. Facility, you have to use the 2008 OPPS final rule if you take Medicare as Medicare patients. They provide 11 points that should be met to determine the level, and your point system should reflect that if there's an outside audit. And then above and beyond these two different mechanisms, payers are now starting to say, I don't want the Medicare one. I want to come up with my own. So one of the ones that we've seen a lot of rub on is Humana. And we're not saying Humana is wrong or right. We're just simply saying there's a disparity between the Humana policy and the CMS policy. Humana gives you examples of what is in a level 1, what's in a level 2. And if you don't document that example to the T, then they're going to try to downgrade it. So if you do take Humana, make sure you have this. Their audit committees might be able to help. I know United has some different policies. Blue Cross has a few. For the most part, they stick with OPPS, but there are definitely differences. I want to take a few minutes and go through these 11 points because these are characteristic. First of all, the coding guidelines should follow the intent of CPT, should be designed to reasonably relate to the intensity of hospital resources and to the different levels of effort represented by the code. That statement has been present since the 2000 initiation of OPPS. Coding guidelines should be based on hospital facility resources. The guidelines should not be based on physician resources. This also has been in the guidelines for facility E&M since OPPS originated, but yet when I go in and audit, I see facilities using or duplicating the physician code, which doesn't have the same amount of resources. The resources must be based on hospital resources. Coding guidelines should be clear to facilitate accurate payment and used for compliance purposes in audits. That means there has to be a policy, procedure, and a demonstration on how to use the solutions if you have tools. Coding guidelines should meet HIPAA requirements. Most of them do. Coding guidelines should only require documentation that's clinically necessary. And this is a big thing as E&Ms are starting to go higher and higher and higher from 3, 4s, and 5. OIG is coming back and saying, you know what, they're coding more stuff because the physician or the nurse is documenting more stuff, and that isn't completely relevant to the resources expended. They're actually doing more documentation for the sole intent of getting a higher level. So this is a trigger point for audit. 6, guidelines should not facilitate upcoding or gaming. And then 7 through 11 actually happened in 2008. So before that point, we had it from 2000 to 2006, these first 6 points. In 2008, they came up with the rest, and it said coding guidelines should be written, recorded, well documented, provide the basis for selection of the code. Okay, now they're saying, you know what, we weren't able to come up with a national standard. We didn't finish with ASAP. We didn't do emergency nurses. We didn't do a HEMA. So if you're going to design your own plan, you better write down how it's supposed to be done, well documented, and provide the basis of that code. Consistently applied, meaning to the clinic or emergency department which they apply. Well, right today we're talking about ER, but you could have different coding guidelines and point systems or however you're going to design it for oncology versus wound care versus ED. They don't have to be the same, but they have to be consistently applied within the area using that document. Coding, here's number 10, and this is one that most people miss. Coding guidelines may be readily available for the fiscal intermediary or MAC review. So they're going to say, you know, why are you all level 5? Show me your coding guidelines. And so this is where an area, if it's not written down and it hasn't been present and you've been coding a lot, arguably they can say, well, you know what, we're going to downcode, or you've been upcoding and we have an issue and we'll pass that on to a government investigator. So number 10 is key. Number 11 is even higher. Coding guidelines should result in coding decisions that can be verified by other hospital staff as well as outside resources. That means I can pick up your policies, your procedures, 5 medical records, and your guidelines and come up to the exact same level that your facility came up as an independent person. No differences. I would come up with the same level. This is in favor of documentation-driven coding. So the documentation in these calculators leads, and everybody will get the same thing. The problem is if you have a human element where you may not get the same level, then that's an issue. And the way to come around this and test for it is yearly annual competencies. You give out an example or a couple examples and have them assign the level and make sure that it meets the criteria so you can show that you're doing ongoing monitoring and testing. The point system diagnosis are proprietary. It must be assigned on these 11 points. And again, caution should be applied with automated ones because there's some questions that auditors will ask you. You have control over the calculations. So at one point, there was a points calculator, and I won't mention who had it, but it consistently upcoded, and everybody knew it, and so did the government. But the facility had no control over the calculations. It was embedded. They couldn't choose the points. They couldn't review the points. And so this is one thing, when you've got a system that's doing the points, make sure your IT tells you that, yeah, you have control over those. Number 2, can the facility adopt them to meet the charging needs? Is the system consistently making 4s and 5s? So look at your revenue and usage, have somebody do a bar chart, and if you're sitting in 4s and 5s, that's an audit concern. So I frequently, when I do audits, I don't look at anything but a year's worth of E&Ms for the facility, and I get my bar chart, and if it shows I never had a 1, I never had a 2, I had 5% of a 3, and everything else is 4 and 5, yeah, you probably a little too far to the right. And this is where CMS is getting very concerned, as is the OIG. And then internal audit of the calculation should be routinely performed against the documentation. That means your internal audit department or your coding staff or somebody who's not involved in the charge capture process or the documentation process, basically independent, should review against the documentation. So E&M, we've talked about that, 11 points for Medicare proprietary. CMS is concerned there's a shift moving. And to that end point, they have developed in the PEPR a category, which is one of the few outpatient categories. The PEPR looks at mostly the inpatient, but in this case, in the acute care facility, outpatient, and one of the categories is level 5. So if you're an outlier, it's more trigger possibility for an audit. These have to be audited randomly to determine the level assigned and supported, and audit immediately after system upgrades. I went through something last year where there was a system upgrade and a points calculator was involved, and all of a sudden I got a call from finance. Our E&Ms are all one. We've lost X amount of dollars. What's happened? Well, it turns out that with the upgrade, somehow it overrode the ability to use the calculator and was only triggering for low-level E&Ms. So again, you need to audit after a system upgrade. And usually IT is pretty good about doing that, but you're going to want to go back to them and say, you know, when there's a system upgrade that affects my points, I want to have a look at it. We're going to switch gears and we're going to talk about trauma activation. This is, for whatever reason, pretty straightforward but fraught with errors. The American College of Surgeons gave the criteria to CMS way back in the day, 2006 it started, and in summary, they had NUBIC come up with a revenue code that starts with 6.8. That's the 6.8 series is for your trauma activation, and they're only for hospitals or centers designated by the state and local government and verified by the American College of Surgeons. So you just can't have a hospital and you decide you're going to be a trauma level. You have to go through very specific credentialing. Different subcategory revenue codes are the third digit, actually the fourth digit, because all revenue codes start with a 0, is the trauma level that you've been certified at. So if you have 681, that's going to be a level 1, 683 a level 3, 684 a level 4. And then the key here is only patients for whom there has been pre-hospital notification based on triage, pre-hospital caregivers who meet local, state, or American College field triage criteria or delivered by inter-hospital transfers are given the appropriate team response that can be billed as trauma activation. I cannot tell you the number of times I've seen trauma activations in elevators and in the parking lot. There was no pre-hospital. We will tell you in a minute how to handle that. But at this point, if you want trauma activation for any payer, you must have pre-hospital designation, and it has to be notified in advance. Trauma activation for Medicare, traditional Medicare, you get a critical care of 31 minutes or more, and the trauma activation, you would use the revenue code specific to your level and GO 390 as the HCPCS code, and you would then therefore get your trauma activation. It needs to be 31 minutes of facility-based critical care. So look at your trauma sheet, your code sheet. Is it 31 minutes of facility care? Because you shouldn't be depending on the physician documentation. This is an E&M too, and you need to have facility resources. Again, you have to use the 6.8X series. And then you can have trauma activation without critical care. You didn't have 31 minutes. There are multiple times there are field activated traumas. You get there, the trauma surgeon's there, and he says, you know what, this is a general orthopedic trauma. They do the FAST exam. They do a quick trauma stuff. It's over in 10, 15 minutes, long before the 31 minutes. You're going to apply the 6.8 series with an uncoded line with the charge for activation. And usually it's a lesser charge. And they call it or hospital activation or, something different. There's usually a tier for these. And this would be a lower tier. And then you also charge the E&M that you would normally charge with your revenue code 450. So it could be a 4 or 5, but you want to be able to get your resources on that bill for trauma activation, even though you didn't get to critical care, and you put that on. Some payers will pay it separately, some will bundle it, never really know, but if it's not on the bill, that's not going to get there. Trauma activation for other payers is quite different than Medicare. Most will follow Medicare pre-hospital activation and what have you. However, they will use the trigger of field locator 14 on the UB. If you don't have the 5 in that trigger, they're not paying trauma. And this is a registration issue. And a lot of times I don't see 5. And you have to train your registrars or whoever's putting this in to make sure it was a 5. One consistent non-Medicare requirement is they call it the gang of 6. And that means there are 6 elements by the American College of Surgery and trauma surgeons that they say constitutes a trauma. And so Blue Cross and Aetna, Cigna, Humana, UHC, they're going to want to see these items documented in the record. So was there confirmed systolic blood pressure of less than 90 in adults and age-specific hypotension in children? So basically, is their blood pressure too low? Respiratory compromise with either obstruction or intubation. Use of blood products to maintain vital signs in patients transferred from hospital to one hospital to another. So if you're transferring a stable patient from one hospital to the next, you can't really have trauma activation. They have to meet one of these 6 criteria. Discretion of the emergency physician. Gunshot wounds to the abdomen, neck, or chest are always considered trauma. Glasgow Coma Scale for neurology, less than 8, with a mechanism attributed to trauma. So basically, why is their neurologic state in 8? Well, they have a head trauma. Okay, it was not in the first 5 bullets, but it now is causing them to have a neurologic deficit. So when you're dealing with other payers, I highly recommend in your documentation, you have these 6 items and you check them off, because if they're not there, you're not likely to be paid trauma and they'll try to downgrade it. We're going to go now into surgical and medical procedures. And the concern here is there's no documentation-driven charging for the most part. Templates are not complete, or they're rarely found for surgical documentation. Nursing fails to document the procedure at all on their side because maybe the doc or the PA or nurse practitioner, one in the room, did the laceration repair, and we call it a silent repair. We walked out of the room, the surgical tray was open waiting for the PA, and we come back, the patient's being discharged. A laceration, a failure to document links and locations. Templates within the EMR are difficult to use, and they leave room for erroneous or incomplete documentation. So we highly recommend you come up with templates specific to your highest surgical procedures in the ED, be it IND, laceration repair, foreign body removal, fracture care, whatever it might be. Represent reimbursement. This is a huge loss. It represents reimbursement that usually is higher than the E&M level. So I will see people go to great extents to document their point system and totally forget 2 laceration repairs. They didn't document it at all. So when you're looking at surgical procedures, they're 10,000 through 69999. And this group lends itself to both hard coding and soft coding, and or both, different categories to both. So you need to understand and have a grid of all your CPT codes and who's responsible for them. So if it's going to be casting and splinting and it's HIM, you know it's HIM. That means you need a casting and splinting charge for which HIM can then attach the CPT code. Central line insertion, same thing. Incision and drainage, same thing. Live birth. But a Foley, Foley can be done automatically. Could be hard-coded. A lumbar puncture, so there's only one code for that. So maybe that can be done automatically. So you want to look, intubation definitely can be done automatically. So you want to look at those elements that are variable. Whenever there is variability in the documentation to arrive at a code, such as length or width or location, then HIM should do it. If it's done the same way every time, and regardless of patient or location, then the CDM should do it. When I look at surgical documentation, those facilities that have a template in their EMR for cardiac arrest, for trauma activation, for live births, for line insertions, pleural taps or chest tube, fracture care, when I see these, lumbar puncture, when I see these templates where nursing can pull up the template and document in it, it makes the charging much easier. Excuse me. So when you look at this, there has to be some sort of procedure note, and that's what frequently gets missing. Or coding looks at just the description of the procedure note, and they don't read the whole note, therefore they come up with the wrong answer. So the templates have to be designed in such a way that coding gets in a top synopsis what they need in order to come up with this. Your medical procedures are more often CPT code that could be hard-driven, like an EKG or rhythm strip, pulse ox treatments, pulse oximetry or treatments by respiratory, cardioversion, CPR, transcutaneous pacing, echoes, and sedation. I will warn you in advance that the 3-lead rhythm strip that just is on your monitor 24/7, every single patient that when you turn on the monitor doesn't constitute a 3-lead. There has to be an order for that. An order for cardiac monitoring does not equate into a charge for a 3-lead. There has to be actual orders to these. Same thing with respiratory treatments. You know, who's doing them? Nursing or respiratory? Respiratory is probably going to be able to get the CPT code. Pulse oximetry is another one. You can't really charge unless there's an order in medical necessity. So just because you put the thing on their finger to make sure that their vital signs are stable and they're taking good care of them, that's considered the care process. That is not separately billable. Obviously, the rest are separately. Supplies are one category that charges are lost at a huge rate because of late charges or lack of barcoding or borrowing from other departments, things like that. Not more and more, there's not a lot of money in this, but we should be able to know that the cost of giving these things is hitting our value-based care side. So it's not just about the reimbursement. We have to look at cost management. The usual culprits in incorrect CDM where supplies come from another, like a Lawson or a supply chain module, and they link it to, you know, something other than it is. And the one I see a lot is an ankle stirrup versus a knee splint. They've got those knee splints as some sort of other thing other than it is. So I always say, look at the box. The L code on the box is going to tell you exactly what it should be. So the supply linking is always an issue, and if there are surgical preference cards within your system in the ED for like a lap repair or something, I see the preference cards are seldom updated when you get new supply items or use more supply items. So supplies are one area that you really have to buckle down and look at because they are frequently missed. And I can tell you as a nurse and as a PA, I totally forget to bill for these. I'll put somebody in an ankle stirrup and I will totally forget to bill for it. And that's why automated charge capture reviews, you'll see the order for it, but you don't see the charge for the supply. Other ways of looking at this is basic inventory control. Your stock on the shelf should equal what was charged plus what's remaining on the shelf. If you keep finding things that are running out or you run out on the weekend, and you shouldn't because according to supply chain you have plenty on the shelf, that's an indication that you've got a charge capture issue. It's going to hit your budget. It's going to increase the patient, and without any opportunity to capture the charge. You should charge for everything. CMS requests that you charge for all your resources. This is certainly it. We see a lot where stuff isn't barcoded, where there's stickers. I know when I was on the sticker system, it was a badge of honor that got stuck in my washing machine because they were all over my scrubs. Was there a failure to just charge it? I took it off the shelf and I never bothered to charge it. So more and more we're seeing electronic scanners as you leave the supply room or the supply cart area, where you just grab it right then and there. So you need to find out why your stock's depleting and remediate it. Pharmacy is one area where it's generally pretty well tightly controlled by pharmacy, by a Pyxis or something, but the loss charges here are actually in the math. So for example, the dispensing unit and the billing units are seldom the same. And one of the frequent offenders, and I put it out there because it's a high volume offender, is ondansetron or Zofran. It comes in 4 milligrams per 2 cc's. And I frequently see either a charge of 1 unit because it was the whole vial, or 2 units because it was 2 cc's, but I seldom see the 4. So when you're looking at these, you have to take the dispensing value and turn it into a billing value. And this is one area where pharmacy in general, across the board, not specific to the ED, is an issue. It's in the math. And so that's one of the things. Failure to credit drugs pulled, that's another one. Charge capture will depend on the method of dispensing. So if it comes from the pharmacy, they're usually going to dispense it, but it won't be charged until it's entered in the MAR. However, you can get a conflict if you use a Pyxis, because a lot of Pyxises charge on dispensing. The ones that are set up correct go from order to dispense, be it pharmacy or the Pyxis, and then to patient. And when you're at the patient, you scan your badge, you scan the order, you scan the drug, you scan the patient. It's a 4-step process of identification, and it cuts down on your risk from wrong med errors. Orders matter. So verbal orders with the intensity of an EDU on a busy night or busy day, you know, a lot of stuff is verbally said between the residents and the attendings and the nurses and the PAs, like, yeah, give them 20 a K. Okay. And then I forget to write that I wanted 20 a K on the patient. So that's an issue. And by the way, K is potassium. A verbal communication not backed up by an order. So it's up to nursing to make sure they have an order if they did things. The other thing, I mean, it's probably not correct, and we're not saying you should ever do it, but we do know that nurses will, when docs and PAs and nurse practitioners are super busy, they'll know what's best for the patient, and they'll give him a medication, and then they totally forgot, and they document it, but they totally forgot to get an order for it. And this happens all the time. And Narcan's a big example. You get somebody in who you know is going to be an overdose. There's no doc to order the Narcan. You give them the Narcan and forget to get the order after that. Another area is orthotics and prosthetics. So those things that are hanging out on your shelf, your neomobilizers, your splints, your slings, your figures of 8, all of those things are separately billable. You do not need a DME license. They are designated by L as in Lima HCPCS codes in your HCPCS book, and you should go and look at them. Also, you'll find it on the box. These should be billed with the L code on it. It's totally appropriate to bill it as a facility. They're not DME. They're not wheelchairs, walkers, canes, crutches. Those things are DME, but these are things that are actually billable by the facility if you have a order. One of the problems we have with apply splint order, what kind? Did I want it plaster? Do I want it fiberglass? Or do I want an orthotic that comes out of the box? The orthotic is an L code. It includes fitting and adjustment. It's a one-time thing, and it may or may not be reimbursed, depending on the payer. However, if I wanted like a splint, a gutter splint applied, and I had to manufacture it, that's a 29X CPT code, and that is a surgical procedure separately reimbursable. So you want to look at your splinting and casting overall. Charge capture. Difficulty arises when charge capture is more manual and not data-driven. Nursing and medicine become key, and it's dependent. Frequently, physician orders and charge entry. ED will enter the charges. Rarely are charge slips still in play, but they are for downtime. Manual charge capture requires there's charge reconciliation for sure at the end of the shift. And manual is not the most accurate when you compare it to a system generated. And make sure that the charges are on the right patient account. So we're going to do our polling question number 3. And that question says, in your facility, who's responsible for daily charge reconciliation or charge capture? 1, the department entering the charges. 2, a specific group of charge entry analysts. 3, patient financial services or business office. 4, information technology from a charge slip. Or 5, other. Again, your facility, who is responsible for daily charge capture, department entering the charge, the specific group of charge entry, the patient financial services, IT, or other. I'll give you another 5 seconds to answer the questions and we'll close the poll. We're going to close the poll now and see what the results are. And the department entering the charges, that's probably the most. A specific group of charge entry analysts, there's a fail-safe mechanism there in that they will ask questions about documentation. Financial services, they don't have a lot of insight into the department mechanisms and processes, so you may lose more charges with them doing it after the fact. And then other. Most of the time, these charges are entered through some sort of automated with the department, but you can have charge entry analysts, and they do offer like a secondary look at it to see where you're maybe looking for lost charges. We're going to move on now to the charge categories of hard-coded and soft-coded. And the hard-coded are those that are placed on, provided by the CDM. They're going to be evaluation, management, supplies, medication, and some medical procedures. These are things that are done the same way every time, regardless of location or setting or patient. Soft-coded, however, requires documentation for which a trained human being can come up with the appropriate rule using coding standards, and there are surgical procedures. The decision to discharge, however, is a real point where you're looking at reimbursement issues. One, most are coming in now under observation. We got to get that MOON statement for Medicare, and patients need to know they're coming in as observation. For non-Medicare, there's usually a requirement to identify that the patients come in the house within 24 hours, and then for patients discharged to home, it's an opportunity for home care or whatever their follow-up. So each of these decisions come with requisite requirements that ensure compliance and accurate reimbursement. So at the time of patient discharge, this is a lost leader. Full and complete registration must be completed. And again, I say the bedside because the doctor can't discharge them. Usually on your whiteboard, it goes to green or you have an insignia ready for discharge. Nurse goes in, pulls IV lines, starts doing discharge instructions, but the patient needs to have their registration completed at that point. The second thing that happens at the bedside is a collection of copay and deductibles. Obviously, if you tell somebody, see them at the desk on your way out, they're going to walk out. Why would I pay? Or you get the bill me later thing. When you're there in the bed, they tend to collect copays at a higher level. So this is an opportunity with the bedside relationship is to talk about their financial responsibilities as well as their full operations with their demographics. So we then get into phase 2 billing, and this is the point where everything's been complete, the itemized been corrected, and it goes through scrubbers. The phase 2 billing, the itemized created, and we're going to go through internal claim edits. An 837I will be created by your billing system and sent over to the claim scrubber. Now, this can be an internal claim scrubber that you've designed or an external claim scrubber, SSI, ePremise, Change Healthcare, something like that. If the 837 passes these 2 scrubs, it's then sent on to a payer for reimbursement. The goal here is that 98% or greater of those claims coming from itemized through those 2 scrubs go to the payer as a clean claim for payment and not rejected. Then the claim is adjudicated by a payer. If the itemized claim fails the internal edits or scrubber edits, then, and there's a pattern to this, not a one-off, you need to figure out what's going on and get reimbursement looking at it. Post-adjudication 837 can also look for the patterns of behavior for lost charges. So you take what went to the payer for reimbursement and you start using rules and scrubbing it and saying, okay, what am I missing? So one example is you won't see it on an 837, but you'll see it on an itemized. You get a charge for an endotracheal tube without intubation. So you want to look at things like implants, things like that. And most often the 837s do better on the inpatient side. So we're going to fight charge leakage now. Basic causes are late charges, charges not documented completely, documentation without a charge, so that's a lost charge, failed processes, system issues, mapping, CDM, staff or human, especially when you have floats, per diems, and casual staff, and any combination thereof can cause charge leakage. The net opportunity, however, according to HFMA, in one of their studies, is 1 to 5% of your total charges is deemed to be a lost charge where you lost net income opportunity, not just gross charges, but net income. And while Medicare may not reimburse separately for percentage charge payers may. So you want to look at prosthetic and orthotic that not payable separately under OPPS, but they might be under a percentage charge payer. So you can't say, I'm not going to code these drugs because I'm getting additional reimbursement from Medicare. Well, no, but you would possibly from a percentage charge. So just don't forget that. Pre-bill edits seem to be the safety net that is the new benchmark. Epic uses a system called Epic Revenue Guardian. These are a manual set of edits created by the facility without the assistance of Epic. It's just a blank template. It's a series of generated, maintained rules. And generally, when I go in, if I see 50 or 60 of these rules, I'm impressed. There are some that have hundreds. Then there are proprietary systems out there that perform rule checks. And these usually have hundreds to tens of thousands to even a million rules and components to check against things that normally should be seen together. They take it from the standard analytic file, they take it from claims data, they take it from payer data, they get all these different rules together to start to check for it. So the example I already gave was the endotracheal tube was charged, but there was no intubation. Many of these systems use pre-bill to identify your lost charges. Overcharges in excessive units. So I've seen drugs where there's like 10,000 units. It's a big mistake, or $10,000 for a very cheap drug. So it looks for that. Identify units of service that are below the threshold or exceed a medically unlikely edit or payer guideline. Inaccurate supply to procedure combinations. So, looking for a gutter splint of an upper extremity, but the patient fractured their lower extremity. Identify medications that are charged with less than what we would clinically expect. So, heparin is charged in 1,000 units. So, and you only charge 1 unit, then nobody's getting 1,000 units for, to remove a clot. So, clinically expected. And then duplicate charges. It catches these all the time. The goal is to ensure charges are present for the documentation service and the quantities are correct and move to the billing cycle. So I'm going to quickly take you through a day in the life of a charge capture professional. They're responsible for isolating and correcting missing and inaccurate overcharges, and the team may work in a facility. You can do either itemized or pre-bill or post-bill. In the itemized, they're working in a pre-bill status, post-bill in 837, and they usually work according to their specialty, be it payer, government, non-government, service line, high-dollar claims, and generally I see service line expertise. They set up a work queue through case routing, so Bill Malm is going to get Medicare, ER surgical procedures, and that way that's my specialty and I keep that going. It's also helpful because case routing can be then changed for holiday staffing and what have you. They will be looking for those 4 components that we talked about, and they'll review consistently identifying potential charge aberrancy, missing charges, overcharges, charges together that don't make sense, or duplicates. So in the day of the life, we see example level 5 without any charges like radiology, lab, or procedures. That might trigger a rule flux. Zofran at 10,000 units. Laceration without a laceration repair. So here are examples of what rules normally catch to help you and guide you to review that record and capture that charge. The charge is identified by the software. However, the professional will go and audit it. If there's accurate, no actions taken. If it's inaccurate, then the professional will credit it, change it, whatever they need to do, and finalize it for the scrub. This is kind of similar on the post bill, but in this case, the ships left the station. In fact, you're looking at things that have already been paid by or are close to being paid by a payer, and you're trying to make amendments for a rebill. Your team is usually your revenue cycle integrity team and PFS, and they usually have clinical experience in an area of specialty, and so you will usually have coding experience along or reference for coders. So in summary, it's a significant source of volume and financial reimbursement for the facility, significant source of charge leakage, so you can impact your bottom line just in the ED. Software can identify those aberrancies because they can reveal 100% of the charges versus your limited data set or your human FTE bandwidth. And then the key here is to audit to ensure you're getting everything that you have earned. Discharge can represent an opportunity, again, to get your copays, deductibles, whatever. So we've got just like a minute or so for questions. I'm going to turn it back to Jacqueline. Do we have time to do any of the questions?
Thank you, Bill, for such a great presentation today. Unfortunately, we are just past the top of the hour, so we do not have time to take any questions today, but I appreciate you working with us on this presentation today, and thank you so much for this valuable information that you've provided. I'd also like to take the time to thank our sponsor, Vitalware, for making today's program possible. And finally, thank you to our audience for participating today. We hope you'll join us in the future for another NARI webinar. This concludes today's presentation.